I think being the front face, I get all the credit, but it will be very unfair for me not to mention General Azhar Kiani sitting here, because the initial resistance that we had and the way we had to start this program, I think he deserves a lot of applause for that. And the next is the backbone of our stroke program is our neurologist, Dr. Salman. I think the dedication that he has shown to our program, these programs are not possible without such focused, dedicated people. So I'm going to invite Dr. Salman now to present RIC data here.
Bismillahirrahmanirrahim. Assalamu alaikum. I will start with the recitation of this verse. A'udhu billahi minash shaitanir rajim. Bismillahirrahmanirrahim. Ya ayyuhallazina amanu idha nudiya lis-salati min yawmil jum'ah fas'au ila zikrillahi wa zarul bay' zalikum khairul lakum in kuntum ta'lamun. Believers, when the call for prayer is made on Friday, hasten to the remembrance of Allah and give up all trading. That is better for you if you only knew. Excuse me. Okay. I am Dr. Salman Abdul Qauum. I am working as stroke neurologist in Rawalpindi Institute of Cardiology. Today I will present the stroke program and RIC stroke data. Okay. Every 90 minutes, patient with symptom of stroke present to RIC ER. Moreover, once a week, an in-hospital stroke code is reported. For such patients, RIC acute stroke team conducts stroke code. Stroke code RIC is a cascade algorithm conducted round the clock by RIC acute stroke team as per SOPs. Now I will take you quickly through what members of the team work. So first of them is the triage nurse. Triage nurse triages suspected acute stroke, expedite issuance of triage form, directs the patient to ER stroke bed. In the case of in-hospital stroke, this is done by ward nurse. Time count starts from the ER arrival or onset of symptoms for the in-hospital stroke. From 0 to 7 minutes, the next two members of the team, ER nurse and ER physician, have their role. The ER nurse maintains airway, keep head up, NPO, checks blood pressure, BP, BSR, and SpO2, maintains BP in stroke range as per SOPs. No antiplatelets, anticoagulants, or oral antihypertensive are given initially. And ER physician, in the meantime, assesses presenting complaints, last seen well time, pre-stroke MRS, NIHS, orders enhanced CT brain if stroke is suspected, and then ER nurse shifts the patient to the CT. From 7 to 20 minutes on the timeline, the next two members are CT technologist and telestroke physician. CT technologist performs the CT brain and shares the triage form and CT video on the official WhatsApp group. We are auditing all this data on daily. So according to our audit, in 75% cases, RIC stroke code, in 75% RIC stroke codes, door to CT time was less than 20 minutes. And you can also see the picture of our WhatsApp group. Then the telestroke physician interprets clinical data and CT brain, advises cerebral or carotid angiogram or CT perfusion as indicated, and he also advises referral or discharge in case of established infarcts, ICB, or stroke mimic. Next on the timeline is 20 to 40 minutes. In this time, CT nurse inserts the IV line, especially in those cases which require a cerebral angiogram. CT technologists perform the angiogram or perfusion, and then after that the patient is shifted to the emergency. And telestroke physician interprets CT or CT perfusion which is done, advises IV TPA if indicated, advises mechanical thrombectomy if indicated, or referral if there is core infarct. This is the picture of our newly installed 640 slice ultra fast CT. I will tell the details about it later. Then the next time, the next job to be done is by ER physician and ER nurse from 40 to 60 minutes. There is, if cardiac assessment is done if indicated, written in form consent for IV TP or mechanical thrombectomy. Then monitoring of blood pressure and NIHS, ruling out contraindications for IV TPA, and documentation of all this plan given by the telestroke on the triage form. And the ER nurse does the ECG if required, and starts the IV TPA after the written consent and the orders, and shifts the patient to cath lab if MT is indicated. As per our audit, in 20% cases, door to needle time was less than 60 minutes. Next is cath nurse and stroke interventionist. Cath lab continues monitoring and IV TPA if started, and prepares patient and lab for MT. And stroke interventionist performs mechanical thrombectomy, After MT, the cath nurse shifts the patient to CT for post-MT CT and then to stroke unit. As per our data analysis, in 12% cases, door to groin puncture time was less than 90 minutes. After MT, then the role comes of stroke unit nurse and stroke physician. Stroke nurse starts post-stroke nursing care as per SOPs round the clock. A 12-hourly progress review round is done by stroke physician of the post-MT and post-thrombolysis patient, and they also conduct training session, which I will tell later. This is the picture of our clinical audit. We audit the timings daily, and the meeting is chaired by Vardi, ED RIC. And first acute stroke intervention in RIC was done on 13th April. Since April 2018, more than 7,500 stroke codes are conducted in RIC. And this is the yearly distribution, and it is showing an increasing trend as we are, our program is growing. 24/7 acute stroke service was started on 5th April 2021. Okay, the distribution of diagnosis is that 14% cases had hemorrhagic stroke and they were referred to the neurosurgery units in the nearby hospital. 13% had stroke mimic, they were referred to medical unit in a nearby hospital, and 73% had ischemic stroke, which were further evaluated with CT angiogram. 48% ischemic stroke patients were late for thrombolysis or mechanical thrombectomy because they have established infarcts on CT. Now I will share my RIC MT and IV TPA data. Total mechanical thrombectomies done in RIC are 269, and in these cases, case selection was done on the basis of unenhanced CT-based aspect scoring. And there was increasing trend of the interventions, but due to delay in supply chain of equipment in 2022, we are seeing less MTs. The distribution of, we have given, the treatment distribution, we have given in 47 cases the bridging therapy with IV TPA, and in 222 cases only mechanical thrombectomy was done. TK3 score was achieved in 70% cases, and 6% had first pass revascularization. Vascular occlusion distribution was that 64% cases had middle cerebral artery occlusion, 14% had basilar artery occlusion, and 22% had tandem occlusions. Carotid stenting and MT was done if indicated during intervention of tandem occlusions. Total IV TPA given for acute ischemic stroke in RIC were 162, 47 are given for the bridging therapy, and 115 were given to the patient with small vessel strokes. To monitor the compliance to multidisciplinary rehab and to optimize secondary prevention, we conduct a daily stroke clinic, and we also monitor the MRS, especially at the 90 days, and we record all this data. So according to our data, the 90 days post-MT MRS is 42%. In 42% cases, the MRS is 0 to 3, and moreover, in 26% cases, we achieved at 90 days MRSs of 0 to 1. This is further explanation of that, which also shows a few cuts of mortality. The total mortality reported was 29%, with mortality not related to intervention was 27%. 1.6% was related to mechanical thrombectomy, and 0.6% mortality was related to thrombolysis. To start the program, we have visionary leadership, 24/7 PCI service, cath lab with biplane, 128 CT scanner, 3 Tesla MRI, cardiologist with training in stroke intervention with WIST and ASMIT certifications, and stroke neurologist. And now we have established what I have shown. We are training we have trained 4 more independent cardiology region stroke interventionists. 3 of them are ASMIT certified, and training 9 more. This is the picture of our new 640 slice CT, and due to this, now our selection criteria will be updated from 1st May. Previously, we were selecting cases on the basis of plain CT based aspect. Now we will select on the basis of penumbra, volume, and mismatch ratio calculation on CT perfusion done by this new scanner. And the benefit that we can include cases up to 24 hours if they, the perfusion map indicates the intervention. Our collaborating unit as per MOUs are neurosurgery unit of District Headquarter Hospital Rawalpindi, medical unit and medical ICU of Benazir Bhutto Hospital Rawalpindi, and rehabilitation center with multidisciplinary teams, that is National Institute of Rehabilitation Medicine, Islamabad. We are conducting training courses for RIC stroke team, stroke code drills, stroke code physician course and stroke code nursing courses. These are done on monthly basis, and these courses are conducted by stroke neurologist and stroke physician and stroke nurses who are trained previously. So these are pictures of some international courses which are conducted for the prospective centers which we have, which are now performing the intervention, this stroke intervention. Plans in progress to minimize door to needle and door to groin puncture time, achieve first pass vascularization in maximum mechanical thrombectomies, case selection augmented by automated artificially intelligent software for CT, CTA and CTP analysis, and publication of RIC stroke program clinical audit 2021 initially. Thank you.